Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, this is Annie Rogers, and on behalf of the Attitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled Focus on Inattentive ADHD, the Underdiagnosed and Undertreated Subtype. When someone mostly exhibits ADHD symptoms of inattention, as opposed to hyperactivity and impulsivity, they're said to have a predominantly inattentive presentation type. So in today's webinar, we'll take a closer look at the signs and symptoms of that inattentive presentation type and how it is diagnosed. We'll look at how the features of inattentive ADHD may manifest in daily life and how the presentation type differs from other ADHD presentations. Finally, we'll discuss how individuals with inattentive ADHD can best manage their symptoms. Leading today's webinar is Dr. Mary V. Solanto. Dr. Solanto is the professor of pediatrics and psychiatry at the Hofstra Northwell School of Medicine in Long Island, New York. Prior to joining Hofstra, she was the director of the ADHD Center at the Mount Sinai School of Medicine and associate professor of psychiatry at NYU. From 2017 to 2018, Dr. Solanto was a Fulbright U.S. scholar in the Netherlands, where she conducted research on treatment of ADHD in college students. Dr. Solanto's research on the cognitive and behavioral functioning of children and adults with ADHD, the effects of psychostimulants, and the characteristics of subtypes of ADHD has been supported by grants from NIMH, NIC, HD, and NINDS. She developed a novel cognitive behavioral intervention for adults with ADHD, which was the focus of an NIMH-sponsored efficacy study. The Manual for Therapists, Cognitive Behavioral Treatment of Adult ADHD, Targeting Executive Dysfunction, was published by Guilford Press in 2011. The program recognized as the Innovative Program of the Year by CHAD. Dr. Solanto has served on a study section and grant review panels for NIMH. Currently, she is a member of the editorial boards of the Journal of Attention Disorders and the ADHD Report with Guilford Press. And she serves on the professional advisory boards of CHAD and APSARD. We are so lucky to have Dr. Solanto here with us leading this conversation. I will hand over the microphone to her in just a moment. I just have a few housekeeping items. If you are tuned into our live webinar, please know that you can download the slides now by clicking on the event resources section of your webinar screen. And if you're interested in the certificate of attendance option, look for instructions in an email that you will receive about an hour after we wrap up our live broadcast. If you are listening in replay or podcast mode, visit attitudemag.com, search for podcast 384. That's 384 to access the slides, the webinar replay, the certificate of attendance option, and more. If you support the work we're doing at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Finally, the sponsor of today's webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. You can download Inflow now in the App Store and Google Play Store. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without any further ado, I'm so pleased to welcome Dr. Solanto. Thank you so much for joining us today and for leading this really important discussion on inattentive type ADHD.
Thank you. It's a real pleasure to be here today, Annie, and I'm looking forward to presenting about this important topic. So, I think the changes in nomenclature over the years have created some confusion. So I thought it would be helpful to begin with a brief historical overview that kind of highlights how the changing name actually corresponded to changes in our understanding of the condition. So, many people think that ADHD is a modern invention, but really nothing could be further from the truth. Back in 1900, we have the first description of ADHD of a child in the medical literature. And this was based on presentations that a British pediatrician gave before the Royal Society of Medicine in London. And these lectures were captured and still are available in the preeminent journal Lancet. And he described a condition in children, although he didn't call it ADHD or even hyperactivity, but it very closely resembles that which today we would designate as ADHD. So then fast forwarding a bit to 1937, Charles Bradley, who was a psychiatrist who directed a residential program for children with developmental disorders in Providence, actually made the astute observation that Benzedrine, which is a form of amphetamine, had the effect of calming the children or some of the children who were given it for medical reasons, not for any expected behavioral effect. But they were more productive in the classroom and more cooperative and exhibited fewer behavioral problems. But methylphenidate wasn't actually licensed for use for this purpose in the U.S. until 1955. And then in 1960, we had a well-known theoretical exposition by Paul Wender, who coined the term minimal brain dysfunction, which was to indicate that something was going on in the brain here. We didn't know what it was, and it was relatively minimal, hence the name. Then in the 70s, there were, not shown here, but there was much more research on the effects of the stimulants in ADHD and the symptoms of ADHD. And notably, Keith Connors developed a scale which allowed us to more precisely identify and diagnose it and also look at the effects of medications. So in 1980, we have, I should mention before that, actually, in 1968, in the DSM-2. Now, the DSM is the Diagnostic and Statistical Manual of Mental Disorders, and it includes all the mental and emotional conditions throughout the lifespan, from childhood through adulthood. And this was the first time that anything like ADHD had been mentioned in it, and it was described and labeled as hyperkinetic disorder of childhood. Now, in subsequent years, there was more emphasis, thanks to psychologists like Virginia Douglas at McGill and others, on the attentional problem. And that was designated really more as the primary problem functionally, rather than the hyperactivity. So in 1980, with the DSM-3, we have the use of the term attention deficit disorder. And interestingly, there were two subtypes identified then, plus hyperactivity and without hyperactivity. And both types were thought to have impulsivity. There wasn't much research to support this differentiation at the time. So actually, in the 1987 edition, the DSM-3R, the revised version, they eliminated the subtypes entirely. In 1994, we have the first publication of the DSM-4, and here they resurrected the subtypes. This time there were three of them. Those were maintained in the more recently published DSM-5 in 2013. And I will now turn to that. So, So in the DSM-5, which we're currently using, we see three presentations. Now, in the DSM-4, they were called subtypes, and the label was changed, and I will describe the reason for that. But we do have the first delineation of these three subtypes, predominantly inattentive, predominantly hyperactive, impulsive, and combined. And as one might intuit, the prominently inattentive subtype have high problems of inattention, lower level problems in hyperactivity, impulsivity. On the other hand, the reverse is true for the hyperactive impulsive subtype, which has a lot of difficulty with hyperactivity, impulsivity, less difficulty with inattention, and then the combined subtype that has features and meets symptom thresholds for both disorders. So how do we define this? So we say that the predominantly inattentive, and I'll refer to this as PI, and combined type is CB, just for convenience sake. The PI type has at least 6 of the total of 9 inattention symptoms. This is for children. For adults and late adolescents, one of the new features of the DSM-5 is that there's an adjustment in threshold for adults and late adolescents. So they are only required to have 5 out of the 9 symptoms. And this recognizes the fact that the symptoms tend to diminish naturally over time into adulthood, so that it takes fewer symptoms for any adult to be to have a difficulty or to indicate a difficulty. And for each of these, there's a lower threshold for the other set of symptoms. So the predominantly inattentive type not only must have 6 of 9 of the inattentive symptoms, or 5 in the case of adults and adolescents, but fewer than 5 for the hyperactive impulsive dimension. The hyperactive impulsive dimension has to have at least 6 of 9 of the hyperactive impulsive symptoms. Again, 5 for adults and late adolescents, but fewer than 5 or 6 for the inattentive symptoms. And the combined type has 6 out of 9 or 5 out of 9 for both sets of symptoms. So what are these symptoms? And you may well be familiar with this. But just to be sure we're all on the same page, these are the core inattentive symptoms of ADHD. Failure to give close attention to details, difficulty sustaining attention, doesn't seem to listen, difficulty following through and completing tasks, difficulty organizing, and not unexpectedly avoids or dislikes tasks that require a sustained attention, which is difficult. Often loses things, easily distracted, and often forgetful in daily activities. Correspondingly, the symptoms of hyperactivity impulsivity are fidgets with hands or feet, leave seat in classroom or in other situations. Could be for adults having trouble sitting through a meeting, for example. Running about or climbing excessively. This would not be appropriate for adults, but a feeling of restlessness or a desire to move may be what's experienced. Difficulty playing or engaging in leisure activities quietly, making a lot of fuss and being very active during those events or making a lot of noise. Often being on the go or acting as if driven by a motor, blurting out answers before the questions are completed, difficulty waiting turn, interrupting and intruding on others. So I think what's particularly interesting here is that there are only 4 out of the 9 that actually deal directly with hyperactivity. The first 3, and also then often on the go or acts as if driven. And there's still a misconception, I think, on the part of parents, teachers, and others in the public sphere that the hallmark of ADHD is hyperactivity, and that if the child or the adult in some way doesn't display that, then they can't have ADHD. So you see, actually, even on this dimension, most of the symptoms have to do with impulsivity. Difficulty waiting, difficulty tolerating delay, impatience, doing things without thinking them through first. Now, all 3 subtypes also have to adhere to the other criteria, the other DSM. I'm sorry, this should be DSM. It was also true for DSM-4, but which include that the symptoms have persisted for at least 6 months to a degree that's maladaptive and inconsistent with developmental level, that the onset was before age 7. So this is from DSM-4. The DSM-5 actually revised this to onset before age 12. So we have more latitude there in diagnosing adolescents and adults. The symptoms need to be pervasive. They need to be displayed in more than one situation. For children, that would be home and school. For adults, home and work, for example. There needs to be clinically significant impairment. And it's important to ascertain that these symptoms are not better explained by another disorder. And we'll go into that in more detail a bit later. So one issue has always been, what is the stability of ADHD and of subtypes over time? So, for example, my child is diagnosed with ADHD at age 6. What's the likelihood that he will grow out of this? Or on the other hand, he will continue to have this disorder at, say, age 8, 12, 15, adulthood. And we do have some data on this. And for the purposes of our discussion here, we would also want, what is the likelihood that the child or adult will have the same type of ADHD over time? So Ben Leahy did a study looking at this, kind of a groundbreaking study when it was conducted, and when we were really focusing more on learning as much as we could about the inattentive subtype. And he evaluated 113 preschoolers between 4 to 6 years of age with ADHD. 83 had combined type. There was a small sample of predominantly inattentive type, which is not so common among preschoolers, and 23 with the hyperactive impulsive subtype. And he evaluated them annually over the next 8 years, that is to age 12 to 14. And this is what he found. So looking here, we're looking at the percentage who retain the diagnosis of ADHD over time through each year of the assessment. The combined type is shown as in red, the PI type in blue, HI in yellow. And we see that the combined type is pretty stable. They continued, a high percentage continued to meet criteria for ADHD by the 8th year. It was around 75%. We see more fluctuation in the two other subgroups, and looking particular at the PI type, so that by the end of the evaluation, by the 8th year, only about, well, I shouldn't say only, it was still a significant proportion, but about 55% actually still were diagnosable as having ADHD. Now, what about persistence of subtypes? So here we see on the y-axis the percent who changed to a different subtype over time, over these years of assessment. And there was a very high rate of change for the predominantly hyperactive impulsive type. And we now know from this and from other studies that this subtype is really kind of rare after preschool. And that what happens is it typically converts to the combined type as the attentional demands become more salient. And so it's not that these children no longer had ADHD, they no longer had the hyperactive impulsive subtype. We see some fluctuation in subtype affiliation for the PI and the CB type. But by the end of treatment, 20%, by the end of the evaluation sequence, 20% of these two subtypes had shifted to a different subtype, and the transfer seemed to go in both ways. So it's 20% of the PI type shifted to combined, 20% of the combined type shifted to PI. So what we're seeing here is that the subtype designations are somewhat unstable. And that is what was recognized in the DSM-5. So instead of calling them subtypes, they were called presentations. And that refers to the fact that this is how these individuals presented or appeared to the medical provider or the person doing the evaluation, and that it doesn't necessarily reflect a type that was going to be consistent over time. Now, I'll refer to them as subtype just because it's easier, but you'll recognize that it really now the official term is presentations, which recognizes this instability over time. So I think it's important to recognize that the kinds of impairment associated with inattention are quite different from the kinds of impairment associated with hyperactivity impulsivity. So again, the PI type has the impairment associated with inattention. The combined type has both impairment associated with inattention and hyperactivity impulsivity. So they have the additional problems of hyperactivity and impulsivity that the inattentive type does not have. Inattention is the dimension that is most responsible, if you will, for difficulties with executive function, with academic underachievement at all levels, grade school, high school, college. And it also results in some difficulty with social function, more specifically around being more shy and passive in social interactions. We'll have more to say about that. On the other hand, hyperactivity, impulsivity is more associated with social difficulties, because this tendency to act without thinking, maybe to grab things from another child that you want, to not follow the rules, to jump in and take things or say things that are inappropriate, to be in effect kind of intrusive and disruptive, really makes life difficult socially for kids with the combined type. But that is not the case for people with the inattentive subtype. So you may have heard of this concept of sluggish cognitive tempo. It's a bit pejorative, but it seems to reflect a combination of characteristics that include hypoactivity, being daydreamy, looking or feeling or appearing kind of lethargic, and apathetic. Although the apathy may not necessarily be the case, but to an observer may seem to be the case. It seems to be more common in the predominantly inattentive than the combined subtype, although that wasn't the result of a number of the studies that were done. But it also occurs, interestingly, in individuals who don't have ADHD. And that led to some research that continues concerning whether or not this is really not ADHD at all, that it may exacerbate some of the inattentive problems of ADHD, but it can exist in its own right in the population at large. So the jury isn't in on this issue as of yet. We do know that if a person with ADHD also has SCT, which I will refer to it for short, they are likely to have greater executive dysfunction. So it adds to those difficulties. We did a study that demonstrated that back in 2017. But the good news is that this feature does respond to stimulant medication in adults. So it can speed up this tempo, reduce this kind of longer processing time that seems to be required for people with who have it. So turning now to an issue of primary interest for this particular webinar, let's consider how gender and subtype are related to each other. So these are data taken from a meta-analysis, which is a compilation of a number of large-scale population-based studies that were done in the United States and abroad concerning the prevalence of the different subtypes of ADHD. That study was led by Eric Wilcott. It was actually published back in 2012. It's still definitive, though. And here we see the results for children. So looking across the first row, we see that the inattentive type is actually most prevalent, which may have been a bit surprising, and that the total number of children affected by any of these subtypes was 11.4%. If we look now at the ratio of males to females, we see that that varies. It's highest for the combined type. So for every 3 to 4 males, there's only 1 female who fits into that category. But the ratio is lower for the inattentive subtype. So now we're down to 2 to 1 males to females for the inattentive type, and around the same for the hyperactive impulsive subtype. I'm not going to continue to say too much about the hyperactive impulsive subtype because it's actually relatively rare in clinical presentations. It's interesting that it was as prevalent in this meta-analysis, but certainly for adults, we pretty rarely see it. So looking down here at the results for adults, we see, first of all, looking across the first row, that the prevalence generally has declined quite a bit. So it's only about half of what was reported for children. And that's consistent with what we know, that these symptoms do diminish over time into adulthood. And so that the overall prevalence of ADHD in adults, and this is consistent with a number of other studies, was only about 5%. So it diminishes by half. And we see again that the inattentive type is more prevalent. So let's look at the ratios of male to female. So it's 2 to 1 for combined. Again, it's lower for the inattentive type. Males still predominate, but the ratio is smaller. So these are people who were not actually individually evaluated. They responded to surveys of their symptoms and characteristics, and these were compiled. What about people who actually present to clinics or to medical providers for assessment or treatment? What are their characteristics? And we actually did a study of that when I was at Mount Sinai. So we looked at 104 people who had presented consecutively to our adult ADHD program and looked at the kinds of subtypes that they represented by gender. So just looking over here at the total, we're seeing that males and females were approximately equal. Males presented with somewhat greater frequency, but it wasn't by a large amount, only by about 10%. If we look over here along the first row of the predominance in males, we see that the combined type was somewhat more predominant, but it wasn't far ahead of the inattentive subtype. We see quite a different picture for women, interestingly, so that they had the combined subtype 38.5% of the time compared to nearly 50% of the time for the inattentive type. So they were much more likely to have the inattentive subtype than were the males, who only had 50 to 60%, 50% likelihood of having the inattentive subtype. So, if we consider children referring for treatment, so clinical studies of children as opposed to the large-scale population screening studies, how can we understand these differences? Because in children, the presentation rate and the diagnostic rate in clinics is about 2-to-1 male to female. In fact, some estimates are even higher than that. And here you're seeing almost a 1-to-1 ratio by gender for adults when they actually come to clinical presentation. And I think this is best understood as a result of the fact that for children, parents and teachers are the ones who are doing the referring, and they are more likely to refer kids who are more disruptive, disturbing, and to bring those kids to clinical attention. Whereas in adulthood, people come to under their own steam for evaluations, so that a woman who, as a girl, may have been very well overlooked in the classroom, wasn't disruptive, but was quietly underachieving and maybe quietly having social difficulties, but for shy and recessive behavior, isolative behavior, shy behavior, and so was kind of overlooked. This kid is doing okay. We don't need to worry. Whereas as she becomes more aware of the difficulties in adulthood, she is more likely to present herself for evaluation and treatment. So there are some other key differences between the subtypes. And here we're talking about comorbidity, which is the association with other disorders in addition to the primary disorder, in this case of ADHD. What other disorders are more likely to occur with people who have ADHD versus those who don't? And we see that other disruptive behavior disorders are more common with ADHD. And these include oppositional defiant disorder and the more severe and antisocial condition of conduct disorder. But both of these are much more prevalent in the combined type than in the PI type. So that's much less likely to be a problem for kids with the PI type. Some of this actually also persists to adulthood with these same kinds of distinctions present. Alcohol and substance abuse, similarly, is much more likely to occur in the CB type than in the PI type. Depression and anxiety, so these are what we call internalizing disorders as opposed to the externalizing disruptive behavior disorders. So these are not as overtly apparent, which is why they're called internalizing. They occur with approximately similar frequency in both subtypes. And I should mention here that my colleague, Stephen Hinshaw, did a groundbreaking longitudinal follow-up study of girls with ADHD into adulthood. And he found not only that they at greater risk for depression and anxiety, but they were also at greater risk for eating disorders and even suicidal behavior. And we don't have a lot of firm data on because we don't have large scale testing of this that compared the subtypes with respect to learning disorders. But what we have so far indicates that they occur with approximately equal frequency in the two subtypes of interest now. So, given these comparisons between the PI and CB subtypes and the differences in symptom profile, in the gender distribution, and in the comorbidity, there's been a lot of thought that maybe PI subtype is a different disorder. It's kind of like, a horse of a different color, if you will. And so there's been a lot of research to compare the subtypes on a number of other dimensions that I'll review briefly. And these include cognitive and executive function, social function, heritability, and response to treatment. So with respect to cognitive and executive function, so cognitive here refers to thinking, and executive functions refer to a certain subgroup of mental functions having to do with time management, organization, planning, self-control, ability to switch, ability to inhibit a response, and so on. And these show rather unequivocally that the CB type has a greater deficit in tasks and situations that require inhibitory control, the ability to put the brakes on, the ability to inhibit a response, even though the person may have the impulse to do it, the ability to stop at least momentarily and think before carrying out an action. They also are at greater risk for what we now recognize as emotional dysregulation. So this is the propensity, which can occur in adults as well as children, for temper outbursts, for meltdowns, for displays of anger or upset that are excessive to the situation. So those, which also reflect a kind of a difficulty in self-inhibition, are more prevalent in the CB subtype. On the other hand, these studies show that there's a greater difficulty for the PI subtype with respect to something called processing speed. And this relates to what I described previously as, quote, sluggish cognitive tempo. And we see on tasks and tests that involve visual motor speed or visual search tasks, rote tasks that, simply, they don't involve reasoning, but they might involve things like matching a letter with a number or comparing two sets of symbols and finding the ones that are matched in both. But a lot of them, and people with the PI subtype seem to take longer to do these things. And this differentiation may also include the speed of auditory processing. So in fact, I think many of the cases that are labeled as auditory processing disorder really might be examples of the predominantly inattentive subtype of ADHD. And then, of course, we have now kind of a wealth of knowledge about that subtype and how best to manage it. On the other hand, there were no differences between the two subtypes or greater severity in the CB type for the following: attention with respect to orienting, sustained attention, distractibility, reaction time, and no differences with respect to memory, be it verbal memory, visual memory, or working memory. So those difficulties, which are primarily associated with the inattentive dimension, were fairly similar for both subtypes. We didn't really see any significant differences there, although there were a lot of attempts, including ours, to look at potential differences and different ways of conceptualizing the differences between the two subtypes. Now, there are a lot of differences in social characteristics, which are very interesting. So previous research and clinical observation has revealed that the PI type is kind of slow to respond interpersonally. They have a long latency to response. You wonder if they even heard what you said. You might have to repeat yourself. And even the most loving of parents and teachers might describe them as being in la-la land or kind of tuned out. They have deficits in social knowledge. Like, what do you do when you want to get something from someone? Rather than taking it, what do you do? Or how do you introduce yourself to a friend? How do you make a new friend? How do you join a group of other children playing? They seem to have less knowledge of how you do those things. On the other hand, the combined subtype may know how to do those things, but when the time comes, in the heat of the moment, they're unable to regulate their behavior in order to do those things. So they have an impulse to grab that toy and will proceed to do that. Studies also had shown that the PI type tends to be more passive, combined type more aggressive. And interestingly, some sociometric studies in which children are asked to confidentially nominate the children in their classroom whom they would most like to befriend, and then those that they would least likely to befriend, showed that the PI subtype is more likely to be socially neglected, i.e., children are not moving into their sphere to interact with them. And I think it's partly because they seem kind of unresponsive and they don't give a lot of positive feedback to other children who might want to interact with them. On the other hand, the combined subtype tend to be more socially rejected. They don't have trouble initiating or responding to other kids. They do have trouble kind of playing nicely, following the rules, giving another child a chance to talk or to play or to take a turn. And so that sort of thing becomes kind of unpleasant for other children, and they may tend to reject these children. So these are very different kinds of social functioning for the two subtypes. So we did a study looking at social skills in the two subgroups and on the social skills teacher rating scale, because teachers really have the most opportunity to see how a child is relating to others. And on this scale, a higher score is better. And the comparison group without ADHD are shown in purple, the combined type in red, and the predominantly inattentive type in blue. And we see that both subtypes are quite low compared to the control group with regard to cooperation. What is cooperation? Cooperation is following instructions in the classroom, following the class rules, the school rules, and both seem to have difficulty in doing that for different reasons, perhaps, but still the end result is that they are perceived as less cooperative. We see some interesting differences in assertion between the two subtypes, and this turned out to be statistically significant. So this combined subtype, where as you might intuit based on the descriptions I've given so far, is actually better at assertiveness. The PI type tend to be less assertive about, raising their hand to participate, just responding to a question, sharing their feelings or sharing their experiences. We see an advantage for the PI subtype when it comes to self-control, which is also consistent with what I've described. So the PI type is almost at the level of the comparison or non-ADHD children, but the combined type kids have a lot of difficulty in this area. So, I think these results indicate that there should be very different social skills interventions for the two subtypes. And although a colleague of mine in California at UCSF, Linda Pfeifner, has developed a unique treatment program, including social skills, as well as attentiveness skills and school-related skills for children with the PI subtype, I don't think it has yet been widely disseminated. So another dimension to look at to see if these disorders are really separable is heritability or family genetics. And by way of background, it's important to know that we already have a fair amount of information about the familial aggregation of the disorder. So we know, for example, that if a child has ADHD, that we can predict that 15 to 20% of the mothers will have it, 25 to 30% of the fathers. Again, highlighting that it is more common in males. If we just consider whether either parent would have it, we are likely to find that 40% of kids have at least one parent who has it. Now, twin studies actually provide the most important data that lead us to understand that ADHD is primarily a genetically determined disorder. And in these studies, twins who are identical, who came from the same egg, share all the same DNA. We call them monozygotic. They came from the same fertilized egg. Were compared with fraternal twins who did not come from the same egg. They're dizygotic. They are non-identical, and they share only about half their DNA. So in these studies, they looked at concordance rate, which is the likelihood that both twins either have ADHD or both do not have ADHD. So concordance is if one twin has ADHD, what's the likelihood that the other twin has it? Or if the twin does not have ADHD, what's the likelihood that the other twin does not have it? So in either case, you have concordance. And the concordance rate for identical twins is 80%, which is pretty high, whereas it was very much lower for non-identical or fraternal twins. So that indicates that the risk or the vulnerability for ADHD is carried on the genes, that is the primary way that it is transmitted from one generation to the next. And overall, the heritability of ADHD is 70 to 80%. So this accounts for the etiology, the causation of ADHD to a very high degree. Not that other things don't affect it. If nothing else affected it, then the heritability would be 100%, and that is not the case. So we know that other things, the support and the nurturance, the treatment that the child may get, of course, will affect the outcome, but it may not actually eliminate the ADHD. There is still that genetic vulnerability. And interestingly, then one can ask, well, is it the same subtype in the family? So if the father has the combined subtype, will the child also have the combined subtype? And same for the PI subtype or the HI subtype. In other words, do the subtypes breed true? And if that were the case, it'd be more likely that this combined and the CB subtype are separable. They're different disorders, but we don't find that. It's very common to find both subtypes in the same family. So that suggests that what is inherited is a propensity for ADHD, but the subtype is variable. So let's turn now to how adults in particular are assessed for ADHD. Now, there's a great screening instrument that's available for free from the World Health Organization. It's only one page. And the score, it's not diagnostic, but it does yield the likelihood that there is at least a possibility that this person has ADHD and should go for a further evaluation if they wanted to pursue this. The diagnostic evaluation itself often should include a questionnaire rating of the symptoms of ADHD. And one of the ones that's most commonly used is the Conners Adult ADHD Rating Scale, CARS for short. And this asks the person to rate themselves on a whole array of symptoms related to inattention, hyperactivity, impulsivity, even self-concept, and yields a score with respect to how this individual compares to others of their own gender and in their own 10-year span of age. So we know that these things change, as I've implied, for males versus females. They also change over age. So the person really needs to be compared to others of their own gender and age group, which this scale allows one to do. It's very important for the provider to take a very careful history of development, actually right from birth, the pregnancy, the early childhood and adolescent years. Here you want to look for any early manifestations of ADHD symptoms or of any other condition that might help to explain what the individual is experiencing now. And of course, the age of onset is very important, as you saw, to establish one of the important criteria for ADHD, which is that the symptoms some impairing symptoms have to be present before the age of 12. It used to be before the age of 7. It's been elevated a bit to take into account, adults having to think back to childhood, which is difficult. But most cases of ADHD, particularly the combined type, do begin in childhood. It would be unusual if it didn't occur until adolescence. And in fact, not only in childhood, but as with the earlier criterion, the earlier threshold, earlier in school age, before age 7. So, of course, we want to look at how these difficulties are affecting the person's daily functioning and how impairing they are. And it's important that the provider look across spheres of functioning that are important: educational, higher education, for example, social functioning, functioning at work. And as these things are explored, it's important to keep in mind that the way these difficulties are expressed may be different for males versus females. So males may be showing difficulty keeping up with demands at work, getting things in on time, get reports in on time, showing up for work on time. But women who tend to juggle more roles in life may be manifesting problems in the management of the home, in getting the dinner on time, getting the children to school on time, being able to manage the functioning of the home generally, as well as their own self-care and any job that they might be holding down at the same time. So whereas the core symptoms are similar for the genders, the way that they are manifested will depend on the particular context in which they are functioning, which is likely to be different for females as opposed to males. Now, the PI subtype is a bit challenging to identify, and that's because you don't have the telltale symptom of the hyperactivity or impulsivity. And so you really are just looking for problems of attention. And these can occur in a number of different disorders, including anxiety, depression, learning problems, language problems, autism spectrum disorder. So it would really be important to inquire as to the possibility that there may be symptoms of any of these other disorders that may, in fact, be more relevant or account for the symptoms better than the ADHD, or in this case, the PI diagnosis would. And so it would be important to actually take this into account in order to differentiate inattention due to ADHD or due to any of these other difficulties. And there's an additional complication that having ADHD doesn't necessarily mean you couldn't have any of these in addition. So these are likely comorbid conditions. So you can see that it really takes a lot of very careful inquiry to be able to identify the boundaries, the presence and the boundaries of each of this disorder in order to come up with the appropriate diagnosis or combination of diagnoses. So let's just compare response to treatment. With respect to stimulants, there have been several different studies that have come up with somewhat different results. And the first show that the PI subtype responded best at lower doses. There were no differences in a study we did in terms of dose response for the two subtypes. And then in a more recent study by Pelham and colleagues, he found that there were smaller improvements for the PI type, even at the lowest dose. In adults, this is less well studied. So far, to my knowledge, there have been no differences in the responsiveness of subtypes to the different to stimulants or non-stimulants. But the take home, which has really always been the case, is medication must be carefully titrated for each child and for each adult to know and to achieve the greatest benefit with the fewest side effects. And this involves working closely with the provider to identify and quantify the improvement and the side effects for each of the steps of the medication. And with respect to psychological treatment, if we compare the subtypes, there do seem to be, or they don't seem to be, any differences in response to a typical behavior therapy program. But I think I mentioned that Linda Pfeifner has developed a behavioral program uniquely for the PI type that, again, I think really should be more widely disseminated. But it is available and accessible, and she's published quite a lot on the topic. For adults, in our own study of cognitive behavior therapy for executive dysfunction in adults, we did not find differences in response of the subtypes, and we enrolled a total of 88, 44 in each of the two conditions with the CBT intervention as opposed to a support group. And I'll just mention for interest's sake that we published the results of that study in an article in the American Journal of Psychiatry and published the treatment manual for therapists. And the two most helpful strategies, there was a whole list of strategies that we included in the program to address scheduling, prioritizing, planning, ability to break down tasks into manageable chunks. We included a session on mindfulness, but I think it's helpful to know that the two strategies that were consistently rated as the most helpful. And this was not only for the adults we treated in this study, but also in some more recent work I've done with college students were the following. So I think it's good to keep in mind the two most helpful things toward being organized and managing time well were planner use. And when we discussed that, I highlighted as this is your roadmap for the day. Without it, you will take a meandering route and may never get to your destination. And we have mantras to help people to internalize and remember these strategies. And one of them is, if it's not in the planner, it doesn't exist, meaning it's very unlikely that you're going to do this thing unless it's something that you can hardly wait to do. And those aren't the things that people with ADHD or even the rest of us typically have trouble with. So in order to get those things done, they really have to be have a time allocated for them in the planner. The other one, which is equally helpful, is what we call chunking, which is breaking down an aversive or unpleasant task that is being avoided, that is the focus of procrastination, into more manageable chunks, either with respect to the amount of the task you're going to do or the time you're going to spend doing the task. And we find that this is very helpful for individuals and with and without ADHD. And my colleagues also practice it in order to overcome procrastination. And here the mantra is, if I'm having trouble getting started, then the first step is too big. So that's the cue that I need to do something here to make this task feel less aversive to me, either breaking it down by time spent or by amount that would be conducted or carried out. So, by way of summary, I think one takeaway is that the PI subtype is characterized by problems that they don't have. They don't have the difficulties associated with inhibitory control or emotional dysregulation and the comorbidities associated with those. So they're similar with respect to the core inattention symptoms and the impairment associated with inattentive symptoms. They have less difficulty with behavioral inhibition, self-control, and emotional self-regulation. They have less comorbidity with the externalizing disorders, equal comorbidity with internalizing disorders, more likely to have slow processing speed and maybe some features of sluggish cognitive tempo. They do have correspondingly different types of social difficulties. And I think here we really need a concerted effort to develop interventions that address these kinds of social difficulties as they occur in the two different subtypes. And children with PI may differ from those with CB in response to stimulants. I think the verdict isn't in yet, but we have not seen differences in response to behavior therapy or, as I described, to cognitive behavior therapy in children or adults. So I'm happy to take questions at this point, and thank you for your attention.
Thank you, Dr. Solanto. That was an extremely thorough and helpful overview of inattentive ADHD, as well as treatment suggestions. And I will get right into questions. I'm going to just do a quick thank you to Inflow once more for their sponsorship and remind everyone that you can download their app in the App Store or Google Play Store. But I will say, probably one of the top questions we've gotten relates to stereotypes and the role of stereotypes in really preventing people from getting a diagnosis. Specifically, we're hearing a lot from older women. And I wonder if you can speak to how previous stereotypes about ADHD may have contributed to a lack of diagnosis in women. And a lot of people asking, they're in their 50s, 60s, even 70s, should they pursue a diagnosis? They think that they do have the symptoms.
Mm-hmm, mm-hmm. So I think, one of the stereotypes for everybody has been that somehow kids with ADHD are, they're out of control, they're bad, they are different, they're maybe not as smart as other kids, or that it's the parents' fault. And I think that's one thing that really inhibits parents maybe from getting an evaluation. They're afraid that they will be blamed. There's been research by Russell Barkley, for example, that shows that any negative behavior from parents toward kids really is more a response to their difficulties and negative behaviors. It's not like the problems that any problems that the parent may have in interacting with the child are the cause of the negative behavior. So I think parents may be hesitant to pursue that because they're afraid that somehow they will be blamed for this. So there are a lot of misunderstanding about ADHD, and there's often an idea that these kids, they're doing this purposely, or they could stop. How come they can pay attention watching TV, but they can't pay attention to their homework? So that, I think, relates to stigma associated with the condition and may inhibit people from getting an evaluation. As far as adult women go, and older people as well, I think that there may be a belief that, first of all, this is unlikely to be ADHD because that's something that kids have and I never had it. But as I described, women may not have been identified in childhood. They didn't have the classic symptoms of ADHD and so were overlooked. It's not the case that the ADHD kind of developed spontaneously in adulthood. It's really that it wasn't recognized before. And I think adults may often have the belief that even if this is ADHD, that there's nothing that can be done about it. And in particular, there seems to be some belief that adults shouldn't take stimulants, or particularly older adults could have negative effect on their heart. There's no evidence of that. In fact, there is much evidence to the contrary. And as we have shown, not only is medication effective, but cognitive behavior therapy is effective. So it's not the case, as many people may fear or believe, that, I'm too old to change, nothing can be done. That couldn't be farther from the truth. I mean, we have evaluated and worked with people in their 60s and 70s that have been able to benefit, including some who are in our randomized controlled trial that I described.
Very helpful. And we hear a lot anecdotally from Attitude readers that there are sort of inflection points in life that may cause symptoms to become more apparent. So one that comes to mind is middle school. That students who were functioning quite well or getting by, not raising any red flags in elementary school, may face executive function challenges of a higher magnitude. I wonder if you could talk about just the different points in life in which inattentive symptoms in particular may make themselves impossible to ignore.
Right. It's great to refer to those as inflection points where the situational demands change and often increase. So we can often predict that a kid who was diagnosed with ADHD in third grade, for example, is going to have more trouble in middle school because there's so much more to coordinate. They have to change classes. They have to keep track of their books. They don't have them all in one place. They have to go to a locker. They're going to have different assignments for different courses, different teachers. And who's going to keep track of that? It's not like one teacher giving a homework list. And this is what they have to begin actually to function more independently with respect to organization and executive skills specifically. The same kind of quantum increase in requirements for being organized and so on will take place in the transition from grade school to high school, and then again from high school to college. And so it's quite often the case that an individual who had been functioning well at the earlier level will manifest more difficulties when the challenges increase, and particularly the challenges for executive function. And this can occur even within adulthood. So, a single person with ADHD may be functioning quite well as long as they can, catch up on work in the evening or weekends. They don't have a lot of responsibilities outside work. But what happens when that person gets married and even more so has children? So some of that non-work time is really going to be taken up with responding to those additional family responsibilities. And that is often when people come to treatment. I am drowning. I am so stressed out. I can't manage everything. And so that is often a time when people self-refer for evaluation and treatment.
Right.
Better not to have to wait to that point, though.
Absolutely. So it's an important distinction because you did mention that symptoms should be present before age 12, but they may be very easy to ignore before age 12. So the fact that you didn't notice them in yourself or your child does not mean that it's not true. ADHD.
That's true. And it takes a careful evaluator to actually, ask more closely about, was there a tendency to do things at the last minute? Or did this child always have a messy desk or forget what they needed to do for the next day? So the signs may be more subtle, but very often with an inquiry, not necessarily around does your child have attention problems, but asking for very specific manifestations can yield, at least the precursors of ADHD.
Indeed. And I did just want to mention, we had a couple questions regarding perimenopause and menopause. Just wanted to mention that we did have a webinar entirely on this topic back at the end of November. So if you do visit attitudemag.com and go into our webinar section, we could not possibly cover it in a 30-second answer. So we hope that you'll go back and listen to that with Dr. Jeanette Wasserstein. So unfortunately, we have run out of time today. There were so many questions, but you covered so much ground. Dr. Solanto, thank you so much. This was incredibly helpful as an overview. We really appreciate your time in joining us today, and we appreciate everyone who joined us for today's discussion. If you are listening in replay or podcast mode, visit attitudemag.com, search for podcast 384. That's 384 to access the slides, the webinar replay, the certificate of attendance option, and more. If you support the work we're doing at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. So in the meantime, Dr. Solanto, thank you so much. Thank you to the Attitude audience. We hope to see you on attitudemag.com soon.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.